situations. Now, supervision. Supervision is another focus area under CLER. And again, we want to know that, that you are being adequately supervised in your training, that you have not been exposed to conducting any procedures or carrying out any treatment plans without the support that you need. So we have this resident privileging audit that we do. And your program directors twice a year will go into your privileging audit and privileging record in new innovations, and they will look at all of your procedures and determine what level of competency and supervision you will require in order to do a procedure. And this is going to be really important for our nursing staff, because our nursing staff may not know all of the residents and their competencies to provide procedures at the bedside with or without direct supervision. Now, we're favored here at OSUMC because we have a relatively stable nursing staff, and they get quite familiar with our residents across all programs. So they have a pretty good idea of who can do what. And if there are any questions, they can call the attending. That happens very rarely here, luckily. However, we must demonstrate to our site visitors that the nursing do have access to this. Our site visitors also want to know that you, the resident, and the fellows know what your privileging is as it pertains to each of those procedures. So I would recommend that each of our residents go into new innovations and look their privileging up so that they know what their capabilities are. With regard to the resident survey, every year ACGME sends you a resident survey and asks you a number of questions about your training. There are 2 questions directed at your supervision with regard to your supervision. So they want to know, are you over supervised? Are you under supervised? Are you supervised just right? Are you adequately supervised? This information is used in a de-identified fashion to let us know as trainers where we need to make some improvements in your supervision, okay? So we use that data to guide improvement in your training environment. When you graduate, there is an exit survey that you'll complete. And there is a question that asks about how you feel about your training and whether you feel comfortable going into autonomous practice without direct supervision. And so you'll see some responses, yes, somewhat, or no. So we also look at that data in a de-identified fashion to address any changes that moving forward. Our patients receive a patient orientation packet, and our patients really need to know what it's like to be cared for in an academic setting. So not only are there staff that work with our patients, but there are medical students and residents and fellows and attendings and consultants, and their medical students and residents and fellows and attendings. And so we put together an addition to the hospital's orientation packet to let them know, let our patients know that there is supervision by an attending, by senior residents in this arena of academic in an academic health center. So this is provided both in English and Spanish. And we are looking at these packets on an annual basis to see if we need to make any changes with regard to our patient communication. And then lastly, under supervision, we have a beautiful simulation center over at the over across the river at the medical school, we have the opportunity to do some interdisciplinary simulation training where attendings and senior residents and faculty can supervise simulation based on your discipline. And so we have used this simulation opportunity for several years now, and we encourage all the programs to reach out and have these discussions in your didactics or with your program director and faculty, and develop some simulations scenarios that you can use our simulation center to do this. CLER really does emphasize the value of interdisciplinary simulation. So you may want to consider having anesthesia, respiratory therapy, nursing, physical therapy involved in some of your simulations, and that's kind of one of our goals as well. So this is ever evolving, and we're excited to see this come to us as an opportunity. So let's talk about what the levels of supervision are. ACGME has some very specific definitions, and there are about 4 of them that are used, 4 or 5. Under direct supervision, in this case, the supervising physician or the senior resident is physically present with the resident and the patient. So they're there for the encounter together. Under indirect supervision, there are 2 categories. One where there is direct supervision that's immediately available, and one where there's direct supervision available. So there's a subtle difference in terminology, but a big difference in terms of the supervision. So in this case, with direct supervision immediately available, the supervising physician or the senior resident is physically within the hospital, okay? So they're there, they're immediately available to provide that direct supervision. They may be in another area of the hospital, but they're available immediately within the facility. The other category is where the direct supervision is available. And in this case, the attending may not be physically at the site, but maybe at another hospital. It may be overnight, they may be at home, but they are available telephonically or by some kind of electronic modality, either core text or text. We try not to use or text messaging, so we have now core text. So please, if it has to do with patient care, please use our core text within our system that is protected information. Oversight. This is a category which is somewhat unique, and it's and there are some programs, some of the surgical and procedural programs that use oversight or conditional independence as a category. And in this case, these residents or fellows really are at that upper level of mastery. They tend to be the seniors. They have a track record of having excellent competency in these procedures and encounters. And usually the feedback that is done in oversight is the attending provides feedback after the care is delivered. It is what we call a progressive authority and responsibility. So this may be something that your program directors will use. So if you see that in your resident privileging area and new innovations, know that that's what this is. Again, our nurses must have access to the resident privileging logs. So, you know, they will have their own, they do have their own username and password, and it is universal to all the nurses. They will not have any access to any other part of your record. It goes directly to the resident privileging area, and this is how they access that record. Now, again, it doesn't happen very frequently, but the site visitors may ask any of our nurses to go in and look up a resident. So